Welcome, everyone.
Okay, ma.
Kindly do well to mute your mic, please, so that you can hear me and so that you can be able to hear our facilitators for today, please. As you're joining, do well to mute your mic. Thank you very much. So, welcome to today's highly anticipated webinar on neonatal resuscitation. Help new babies breathe. I'll be your host for today, and my name is Ndukwe Queen Esther. At Clearview Hospital, please do well to mute your mic once you join, please. At Clearview Hospital and Fertility, one of our missions is to ensure that we offer world-class maternal and neonatal care, ensuring that every newborn, every baby gets the best start to life. So with me here today, I have two distinguished experts who will be educating us on neonatal resuscitation. The first person with me who will be joining us today is Matron Angela. Matron Angela is a registered nurse midwife who trained in University of Benin Teaching Hospital, Edo State. With over 10 years of experience, Matron Angela is passionate about maternal and newborn care. So Matron Angela will be taking us today on the step-by-step process of neonatal resuscitation. So, Matron Angela, please, can you say hi to the audience? Okay.
Hello, everyone.
Thank you very much, Ma, for joining us. So, the second speaker with us today here is Dr. Nwachukwu. Dr. Nwachukwu is a renowned pediatrician who trained in University of Nigeria and Lagos State University Teaching Hospital for his undergraduate and postgraduate studies, respectively. So Dr. Nwachukwu, in his early years, practiced in various states of the eastern part of Nigeria. And Dr. Nwachukwu is also passionate about newborn care, having participated in and facilitated a lot of neonatal resuscitation programs. Dr. Nwachukwu is also a wellness and fitness enthusiast. So, Dr. Nwachukwu, please, can you say hi to the audience, sir?
Good morning, everyone. It's in the morning. Can you hear me?
Yes, sir, we can hear you loud and clear.
Yeah, welcome, everyone. Glad to be here. I hope we have a fruitful time together.
Thank you very much, sir. So, Dr. Nwachukwu will be discussing neonatal resuscitation before, during, and after delivery. So, stay tuned to hear from our facilitators, okay? Welcome. So, over to Matron Angela. Ma, you have the stage.
Good morning, everyone. Hope you can all hear me.
Yes, ma, we can hear you loud and clear.
Okay. Thank you all for registering and joining this webinar. I feel I feel very elated to have this number of people join this webinar. Okay, so like the moderator said, my name is Angela Rolisa, a nurse midwife. Today we're here to give you tips on how to help babies sleep when they are born. So, first and foremost, newborn babies, while they are in the womb, while they are in the womb, they depend on their mom for almost everything. But when they are born, they are supposed to kind of adapt to extrauterine life. Okay, they are supposed to adapt to outside the womb. And the temperature in the womb is quite different from the temperature outside. So there are steps that we take to help them to breathe properly. Yes, on their own, but they will still need some extra help to help them breathe properly. And these steps, I have kind of like simplified them into 5 different steps that I'm going to talk about here. But let's start with the definition of neonatal resuscitation first. What is neonatal resuscitation? Neonatal resuscitation are a series of actions used to assist newborn babies who have difficulty with making the physiological transition from the intrauterine life to extrauterine life, like I said before. Okay, so this simply means that these are different actions that the professionals carry out when a newborn is delivered to help the newborn to be able to adapt to extrauterine life. Okay, so we go down to the steps. So step 1, first of all, before you start any particular step, mind you that whatever you are going to do for a newborn must be under a particular machine called a radiant warmer, because the temperature of the womb is warm enough and comfortable for a newborn. So when the newborn is outside the womb, wherever the newborn is being resuscitated should also mimic that kind of temperature in the womb. So there is a machine called a radiant warmer. That is where you place your newborn and carry out your resuscitation steps. So step 1, we call it tactile stimulation. Tactile stimulation simply means drying this baby, keeping this baby warm. When these babies are born, they come out with something we call venous caseosa, amniotic fluid. They are all wet, sometimes some of them with blood. So you kind of help them to keep them warm by drying them. As you're doing that, you are observing this newborn. Some of them at that point, while you're doing that, you would realize that some of them pick up even after that and they start crying. There's something also we call APGAR score. APGAR score is a score where while you are trying to help a baby breathe, you are looking out for some certain factors. APGAR score simply means the appearance of the baby, the respiratory rate, the facial grimace, the pulse rate, and all of that. So if all of these things are within normal, if the color of the baby is good and all of that, then you know that what you are doing is actually helping the baby, and the baby will pick up and start breathing properly. Some babies after this they pick up, but if not, if after this one the baby still hasn't made any move, you move over to step 2. At step 2, you clear the airway. Now, like I said, that these babies, they come out with amniotic fluid. Some of them, while coming out of the womb, they tend to swallow some part of this amniotic fluid. And when they do that, it clogs the respiratory tract, thereby not allowing them to be able to breathe properly when they are born. So that's why some babies are born and they don't cry. When you notice that you've tried to keep the baby dry and warm and baby is still not making any effort, you gently clear the airway. How do you clear the airway? You make use of what we call suction tubes. Now, these suction tubes have a particular size for babies that you use. You put this suction tube through the baby's nostrils, okay, gently, and you don't go too deep. You go as deep as 2 centimeters and that's it. If you go too deep, you might end up causing more harm than good. There are tiny vessels surrounding that respiratory tract, so the deeper you go, you might end up puncturing 1 or 2, and then this baby starts bleeding inside, which now results to another problem. So you put this suction tube into their nostrils and make sure the suction tube is also connected to a suction machine. While you're doing that, you're also watching the baby to see if the baby is responding. If all the vitals that you have done before, if they are now coming back to normal, if baby is responding. If after that, baby is still not responding, you move over to step 3, where you consistently stimulate the neonate. You can stimulate the neonate by gently rubbing the back. You rub the soles of the feet too. In those days, some people turn the baby upside down and smack the baby. That is no longer practiced now. So you gently stimulate the back of the baby and the soles of the feet. It will also help to stimulate baby's breathing. The practice of then, yes, I know the intention was to also stimulate the baby, but it doesn't. It's rather a harsh way of doing it. So you gently stimulate by rubbing the soles of the feet and the baby's back. If after all of this, baby has still not responded, you go to step 4. At step 4, this is a step where you it's a kind of in severe cases where after all you have done, because most babies after these 3 steps they pick up and everything becomes normal and you transfer the baby to the ward. But in some severe cases, you need to get your oxygen masks, you need to get your bag masks, you need to get something to ventilate the baby. The pediatrician will also need to get an instrument called for intubation, where he passes a tube straight down into the baby from the mouth down to the lungs to introduce oxygen directly to the baby. So at this point, you use the bag mask and you gently keep bagging the mask. And as you're doing it, the only way you know that what you are doing is effective, as you're doing it, you are looking at the baby's chest. You're also looking at the baby's color. And make sure also that there is a vital signs monitor attached to this baby. Because if all you are doing is effective, you're definitely going to see some changes in the vitals. You are going to see changes in the baby's color too. So you gently bag the mask and then you watch your baby's chest as it goes up and down. And then finally, at this point, baby is meant to pick up. If baby now picks up, you clamp and cut the cord. And then finally, you transfer the baby to the NICU. But there is a
Hello, Ma, are you there with us? Hello, Bertrand Angela. Oh, okay. So, do not be disturbed with the little glitch in network. So I encourage every one of you to please engage, ask questions. You can drop your insights in the chat box. Whatever question you have, just drop it in the chat box and our facilitators will attend to that shortly, okay? If you join us, please do well to mute your mic. So while we are waiting for Matron Angela, let's move over to Dr. Machuko, who is the next speaker, and he'll be taking us, like I said earlier, he'll be taking us on neonatal resuscitation before, during, and after delivery. So he will talk to us on it so we can see neonatal resuscitation from a broader perspective. Sir, you have the audience. So sir, please do well to turn on your video so we can see you. Please, sir. Thank you very much.
The more important thing is that you can hear me, and I'm sure you can see me now. If they can share.
Yes.
Okay. Right. As she mentioned, my name is Dr. Wachuku. I'm a pediatrician, and I will be talking to us a little about what we do when babies
Babies
are
are
born.
So sorry about that. Hello, can you hear me?
Matron Angela, we can hear you, ma. Dr. Michael, please, sir. If you don't mind, sir, continue with Matron Angela, please.
That works.
Thank you very much, sir, for understanding. Okay, Matron, please, can you turn on your video? We can't see you, ma.
Okay, the video is actually on.
Okay, ma, but we can't see you.
But you can hear me.
Yes, ma, we can hear you. You can continue, please.
Okay, so sorry about that. So like I was saying, if finally after everything and it's still not proving to help the baby, then you go to oxygenation. If oxygen is available, connect the ambu bag to the oxygen reservoir at 2 minutes of ventilation, setting it at 2 liters per minute flow rate. And then that helps the baby. Ventilation is achieved. That helps the baby to breathe. So if after all of these steps and it seems like the resuscitation is not helping, your vitals, you've checked all your vitals and they are still not within normal range, it is left for the pediatrician to make a decision at that point. But before you finally wrap up, after resuscitation, you go back and access all of your vitals. You evaluate all vital signs, you look out for danger signs, and you measure all of them. You measure the blood glucose level, whatever you're doing, make sure you record all your results before you now finally do another APGAR score, write your assessment, and then you transfer the baby to the neonatal intensive care unit. Thank you all for listening.
Wow, thank you so much for the presentation. So, ma, let's explore some aspects resuscitation. Ma, please, can you explain why critical that this neonatal resuscitation is done within the first minute of life? Please, exactly, do well to meet your mind, please, so we can talk about that.
I didn't get that very well. You said I should explain what?
I said you talked about neonatal resuscitation happening once immediately a baby is born.
Yes.
So, question is this: why is this that this neonatal resuscitation is done within the first minute of life? Why is it important that it's done immediately the baby is born? Thank you.
Okay. Yes, thank you for the question. I failed to mention that all of these steps that I have highlighted, you are supposed to do all of these steps. You're supposed to take all of these steps in 60 seconds. That's 1 minute. Because after 1 minute, I'm sure if all of you should do a simple exercise of trying to hold your breath for 60 seconds, is going to be very difficult. Now, what happens is that after 60 seconds of not having enough oxygen circulating in the brain, some brain cells are affected. And for a baby, we try to avoid this because the baby might end up having brain damage. So that is why resuscitation should be done within the first minute of life. That's 60 seconds.
If I may just add to that, the whole aim of resuscitating the baby is to ensure that oxygen is going in to ensure that blood is circulating and to ensure that the baby is breathing.
Okay.
Now, in the absence of these three, you find that the vital organs are affected: the brain, the heart, the adrenals, and it greatly reduces the chances of that child being a healthy, normal child. One of the things that she had mentioned earlier was birth asphyxia. Birth asphyxia when there's deprivation of oxygen and nutrients to the brain. What does that do? The brain is damaged, and once it's damaged, it never comes back to where it should be. So the whole essence, the whole aim of doing resuscitation, helping the baby to breathe, is to avoid any of these damages. Thank you.
Well, thank you so much, sir, for this wonderful contribution. So, Mr. Fayosmonye is asking, is there a reason why the old method of stimulation is no longer in use? Matron, please.
Can I also take that?
Yes, sir. Go ahead, sir. Go ahead, sir.
Okay, so you know the newborn baby has a brain that is still very tender and all that. There are vessels in the brain that are very delicate, especially when they are newborn in the early days. All that beating that they do, all the corporal punishments that they used to do then, was out of ignorance. And because what it does is that it can actually lead to the vessels, those tender vessels around what we call the ventricles in the brain, to break because of the force. The vessels break, the child bleeds around those ventricles. So the baby is starting off life at a disadvantage because the part of the brain is already damaged. So it can actually cause brain damage. Gentle tactile stimulation, touching, cleaning, drying, those are things that will stimulate the baby, and that's enough stimulation. The other thing we also have to bear in mind is that we do not actually need the baby to be crying and wailing. No. The important thing is that the baby is breathing, the baby has a good color, the pulse is above 100, and the baby is moving the limbs and all that. What I've just done is give you a rundown of the APGAR that she had mentioned earlier. Once all these things are there, the crying is not an important part of it. There are some times when I attend the delivery and we finish everything. The baby may not be screaming and crying, and by the time I go to remove my gloves and wash my hands, it will be as if they are pinching the baby because they are trying to clean. That is even more stimulation, and the baby, responds to it by giving them the kind of cry that people of the olden days would have been expecting. But the important thing, baby is breathing, baby is the right color, active. We are not really bothered about screaming down the kids. They will eventually cry when they want to.
Okay.
We are helping baby to breathe, not baby to cry. And it's more different.
Okay, sir. Okay, sir. Thank you very much for that. Fidomi Nayeboa is asking what the glucose range for pediatric.
What's the what?
The glucose range for pediatrics. I guess she wanted to write pediatrics like pedics. She wrote pedics. I think she's talking about babies. That's the glucose range, because Metro mentioned the glucose level, while
ordinarily 40 milligrams. We're using 40 milligram, below 40 milligram. Ordinarily is hypoglycemia. That's low glucose. But we also know that babies are quite resilient when it comes to that. We don't want it to go below, but we can still walk around how to take it up. But normally the cutoff is 40. That we need to do something about.
Okay, thank you very much, sir, for that. So Oluwatoyin Sekoni, or Shekoni, sorry if I don't pronounce that correctly, asked, he said, you mentioned using a suction tube that is passed through the baby's nose. How big is that? How big is that? Won't it injure the baby? That's our question.
Okay. The first thing anybody learns in medical practice is that, first of all, we do not do harm. Whatever we want to do, first of all, it must not cause harm to your patient. So the tube that is used, it's quite small. It's much smaller than the baby's nostrils, and will safely be used for the child. The sizes range from size 5, and then you have the adult sizes that are quite much bigger. But the ones we use for neonates are quite small, usually not more than a size 8.
Okay. Thank you very much, sir. Oluwatoyin, I hope you got your answer. So Joy is asking that, Matron, please, while you were talking, you mentioned cutting and clamping the cord. So at what point should the cord be cut and clamped during resuscitation?
I don't know if she's still here.
Matron, are you still here?
Yes, I am.
Okay, ma. So I don't know if you heard the question, ma.
Yes, I did.
Okay.
The cord should be cut at the point when you have achieved your aim, because the cord is attached to the placenta, and that is where baby gets oxygen, nutrients from the mom. So once you cut the cord, that means you have cut off all connections. So if you are sure that your baby is okay and stable and breathing properly, then at that point you can cut the cord. You can sever the ties between the mother and the baby.
Sorry, Mitchell, let me just add that usually, I think what the lady is asking is about the other short one. Ordinarily, to complete delivery, would have the surgeons or whoever is taking the delivery, assuming it's vagina, would have cut the connection, which is the cord between the baby and the mom, before handing it over to us for resuscitation. So it's clamped. I guess we're actually discussing the other short part. It's divided into two. Half stays with the placenta, half is on the baby. So that long one that we need to shorten, shortening it is not an emergency. We can finish all we are doing before we now start using that blue clamp, the cord clamp that is left on the child that drops off after a few days or weeks. But the cutting, the severing between the mother and the child happens once the baby is out of the womb. Once the baby is out of the womb, the cord is cut, and then before it's handed over to us for resuscitation.
Okay, it's okay. Thank you very much, sir. Joy, I hope you got your answer. So, sir, since you already have the floor, you can start your presentation, sir. Thank you very much.
Oh yes, that's fine.
Thank you.
Good afternoon, everyone. We'll be talking about helping babies breathe when they are born. My name is Chimwachuku. Next slide, please. Next slide, please. Thank you. So we'll be using the outline. We'll give a little bit of background talk about before delivery and what happens after delivery. Next slide, please. So, who are the participants when we're talking about neonatal resuscitation? Of course, the mother is there. She's one carrying her patient for so long and so patiently and so lovingly. Then you have I mentioned skilled and unskilled caregivers. Reason being that it's not all the time that delivery happens inside the controlled environment. We know that outside of the hospital, some people have been born. People have been born in cars. If I recall, while I was still in Lut as a resident, we had to go to the pharmacy block to rescue a student who went into labor, and eventually we took the delivery on the staircase. So there are people who are skilled and unskilled that may be involved in the delivery of the baby. Of course, the most important person when it comes to neonatal resuscitation is the baby himself or herself. 10% true. About only 10% of babies born will actually need any form of resuscitation at all. Meaning that 90 of every 100 deliveries can be done anywhere without needing any skills. Out of the remaining 10, about 9 of them probably don't need anything more than a few basic steps that matron had outlined, the cleaning, drying, and all that. And the remaining 1% is where the work is for very skilled help. But the thing is, there's really no way of telling who will fall within the 90% and who will fall within 10%, or who will fall within 10% of the 10%. Except in situations where we've had proper antenatal care and seen that we have anticipated that there may be, the child might be in one of these other not so good groups. The ABC rule, I'll come back to it later. The A, B, and C stand for airway, breathing, and circulation. Neonatal mortality in Nigeria, which is the number of deaths that occur out of every 1,000 live births. In Nigeria, 34.3, and that's quite a very high number compared to 3.6 that they find in other places like the US and parts of Europe. There are many factors that are thought to contribute to this. There's low birth weight, prematurity, birth asphyxia, we had mentioned that earlier, lack of antenatal care, and maternal illnesses, sicknesses that affect the mom. Those are things that may contribute to the very high neonatal mortality rate in Nigeria. Next slide, please. Now, before the delivery, there has to be some preparation. Getting ready mentally, physically, medically. I put the etc. there because the other things will need to be ready financially too, not just for the delivery, for things that will happen after taking care of the child. Before getting pregnant, there are things that also need to be done for the woman. One of the most important things being to ensure that there are no vitamin deficiencies, especially folic acid, because that's one thing that can lead to a lot of effects. Neural, the brain and the spinal cord form first within the first few weeks. Folic acid is actually very, very essential for the proper formation of the brain and the spinal cord and the spine. So if that is not available, you can now have defects or lead to some other thing. Proper antenatal care, very important. There's a robust practice in Clearview, so is a very good place to be to have the antenatal care. What does it do? It helps us to ensure that, okay, first of all, you know how many babies are there. You know the status of the babies. Be sure there are no congenital, any defects, any birth defects. And to plan towards delivery, what kind of delivery is going to be used for this one. And all those are things that I'm sure the O&G people would address at some point. Next slide, please. Next slide, please. Right. Just as an aside, please can you unpin the link on the, it's covering a bit of the upper part of the slide.
Okay, Didami, please can you unpin the link, please, so I can see like properly.
Well, I'll just carry on. At the delivery, one needs to check that you have a full complement of the personnel in a controlled environment like ours. Everyone needs to be there. Usually everyone is there. We also need to check that all the things that we will need are available. And usually they are. You also need to check, even at that last minute, ensure that all the equipment that you have are actually working. There are instances where you take it for granted, and at the point where you need these things, you may not find that suction is not working there and start running up and down like a headless fan. So the way to avoid that usually is to check the equipment before the delivery even starts. I come back to ABC, airway, breathing, circulation. Airway, breathing, circulation. These are the most important things when it comes to any emergency situation medically. It cuts across all aspects. And for the neonate, as baby is brought out, the cord has been cut. We have a wet baby with some activity. So what do? Ensure that the airway is clear, ensure that the baby breathes, and ensure circulation. These things go on hand in hand. It's not like we'll do airway first and then we'll now go to breathing. No, they are happening simultaneously. Now, when you are in this business, you will find that 1 minute can be a very, very, very long time. So as the baby comes out, there's a timer that usually will go off to let us know how far away we are from the 1 minute. Now we assess the baby after the first minute. We are looking at the appearance, we are looking at checking the pulse, we are checking the response to touch and pain, we are checking the level of activity, we are checking respiration, that the baby is actually breathing. And all these things are going on simultaneously. And once we are happy with what we have, baby is pink, the pulse is over 100, very active, breathing fine on his own by 1 minute, we are happy, and then we go on to further management. Next slide, please. Okay, so remember the ABGA, that's what we used to assess. And that is also when we have done the first minute, we also check at 5 minutes, assuming that the child is not responding to our initial efforts. There are a lot of steps to take. As Angela had mentioned, up all the way to intubating, as putting a tube through the mouth, getting close to the windpipes, and then help the baby to actually breathe, at least for a while. The good thing is that we happily do not have to do that a lot. By the time you do the proper things, you've done the proper preparation for pregnancy, you've done antenatal, usually by the time it comes to delivery, shouldn't have any issues taking us beyond just the basics, but we need to, then we'll go there. So for a lot of the children, we just do routine management. They clean, dry, dress up, and they're prepared to have our first meal and all that. That's what happens for majority of the babies. Now for a small set too, we are not so happy, but there are issues that we have noticed and we need to keep a close observation and try and anticipate things that may happen before they happen. Now there are pointers from them, maybe previous pregnancies, what the mom had, or previous issues with jaundice, previous, past history would also let us know. And things that happen at the delivery, ABGA and all that, we're not so happy, or baby was born through meconium, or things like that. So we try to anticipate those issues before they arise. They are the ones that go straight to intensive care. When babies are born a little early, the preterms, the ones that are not so mature, we put them in the intensive care. That way we are kind of trying to provide the same kind of environment they've been in the previous months. Provide them with warmth, provide them with food through the veins, and really, try and get them to mature before we bring them out and then they can go with their parents. The ones that also go ahead to develop jaundice or develop an infection, or develop any of the other things that could happen to any neonate, we also manage medicine. So come to the end of the presentation. Thank you so much for your attention. Take any questions at this point.
Okay, thank you so much, Dr. Wachuku, for this valuable insight. So, please, the audience, if you have a question, do well to drop it in the chat box. So, Dr. Wachuku is there to answer your question. Okay, sir. So, you mentioned that the neonatal mortality rate is 34.3 per 1,000 live births. So, sir, please, we want to know what are the leading causes of these deaths?
Okay, I had mentioned that as part of the presentation, talked about low birth weight, babies born below 2.5 kg, which is normal birth weight. Talked about prematurity, babies born before they are at STEM, before the pregnancy gets to 9 months. Talked about birth asphyxia, those that fail to breathe in spite of all the efforts that have been made as represented by their ABDA scoring. And we also talked about maternal illnesses. Those are things that could lead to neonatal deaths. Some of the things that could lead to it here.
Okay, thank you very much, sir. So, let's go over to the chat box. Philomena is still asking, please, the glucose range, is it measured in millimole per liter, or can I get the range in millimole per liter?
2.2. 2.2.
Okay, Philomena, I get that. So, Josephine Damilola is asking, if the baby starts crying immediately after birth and 2 minutes later he becomes unresponsive, please, what can be done?
Right. So, a child that comes out, everything is fine at the first minute, and then by second minute there are issues. That's where they're calling some of us. There are a few things that could have happened. One of the things, I remember Angela mentioning that you do not take the tube too far down. When the suctioning is over enthusiastic, you can trigger a reflex that cuts off respiration. It's called the vasovagal reflex. So it cuts off, shuts off the respiration, shuts off the heart. That's like the baby faints and is not breathing anymore. Okay, so what happens then is that we now have to go into active resuscitation. If the heart rate is not there, we are doing, like I mentioned earlier, ABC. Check the airway, check the breathing, and then we help with the circulation. So that what happens is the baby suddenly drops back after 2 minutes.
Okay, thank you very much, sir. Ogumpi Ifejola Yomi is up. Good afternoon. Thank you for the presentation. Is it advisable to administer vitamin K injection during resuscitation?
Okay, so if you had followed, you would have seen where I said routine management. I didn't want to go into all the details that go into routine management. Yes, every child that is born gets vitamin K. The reason being that ordinarily the vitamin K is made in the liver, and for a majority of the children, the liver is not yet at 100%. So you want to give that as a stopgap while the liver catches up. Vitamin K is very important when you talk about clotting. Small clots, for bleeding to stop anywhere. Vitamin K is very important. There are factors that are dependent on it. So we give them that as a stopgap while the liver picks up and continues from there. So yes, they get vitamin K, but it's not part of the resuscitation. It's part of the routine management after you have done resuscitation.
Okay, sir. Ifejola, I hope you heard Dr. Wachuko on that. So she's still asking, is there a difference between NICU and SCBU?
It's nomenclature. It's what you call your dog. That's what you answer. But they are the same thing. They represent the same thing. Neonatal intensive care.
Okay. Okay. Ifejola, you heard that. So Akinyemi Damilola is asking, sir, please tell us how to go about the chest compression to help circulation in the neonate.
Okay. Now, you're talking about life support. So chest compression for a neonate, you actually need 2 fingers and place on the sternum. That's the part of the chest just below the notch there, and then just make a depression. Don't use too much force before you go and break some other thing. But what you're doing is you just push the heart and see it to jump start it. So 2 fingers for a neonate, you just need 2 fingers to do that.
Okay. That's what's like, because I believe most persons here are health practitioners and nurses. They want to know at what rate, how will they go about it using 2 fingers? How many times?
Well, Esther, we are doing neonatal resuscitation. So that's what we are moving into, basic life support now. That's a different course altogether.
Oh.
But those are things that we can. It's a vast topic. So if we want to, we can actually arrange to have that as a different, a separate webinar. But it might be nice to keep ourselves within what we are discussing.
Okay, sir. Thank you very much for that, sir. So, Love Okikiola is asking, at what point should the newborn be fed or put to rest after birth? If the glucose range is below 40 mg per day, what measures should be put in place?
Right. We feed. That will be the first thing anyone will want to do. Assuming that all other factors in place. Baby doesn't have any issues requiring further management, like taken to the intensive care or high dependency. If there are no other issues and the baby is being managed, feed as soon as is practicable. As soon as is practicable. The teaching actually is that once baby is delivered, you put to breast before doing any other. A baby is born and the baby is fine, so what you do is just put to breast. But the practical thing is that to feed as soon as practical. That is also why we check the blood sugar. There are things that could make the blood sugar go down. So if we are dealing with the child of the mom that has diabetes, either straightforward diabetes or the one that is induced by being pregnant, we expect that once they are born, because they have on their own system now, the high insulin will drop their sugar. So we anticipate that, and we try and feed as soon as it's practical. And that usually solves the problem. If it doesn't, then we need to correct. Otherwise, then baby has a line and then we can correct with extras.
Okay, thank you very much, sir, for that. Please, the audience, if you have questions, just keep your questions coming. So, sir, Joy is asking, is it compulsory that all babies should be suctioned even when the baby's vitals are okay?
Nope, it is not compulsory. But again, like I mentioned, it's a dynamic thing. You're managing that particular patient in front of you, a particular baby in front of you. I had mentioned earlier that 90% of these babies can be born in the market, and all you need to do is to tie, and baby is fine. Okay, so it's not every child that will need the suctioning. Yeah. So the ones that do not need, you don't have to. Remember, I also mentioned the vasovagal reflex.
Yes,
when
sir.
you go to suction, you can also stimulate that and baby drops.
Okay. Thank you very much for that, sir. So, God Blessing is asking, what is the type of vitamin 1 and 3? And the dosage of vitamin K given to newborns. I guess she's asking what's the type of vitamin K given to newborns. Is it vitamin K1 or K3? And then the dosage for the vitamin K given to newborns.
Okay, I'm supposed to answer that. Okay, so there are drug formularies. People do not carry these things in their head. There are too many things for one to think about, but there are resources you can check and get dosages from. And I'm going to leave it at that.
Okay, thank you very much, sir. Thank you very much for that, sir. So, please keep your questions coming, and while we are waiting for that, sir, what are the next steps like to take if a baby scores below 7 on the ABGA score?
Okay, so there are classifications of asphyxia. You have the mild, the moderate, and the severe. For the mild, even though there are different opinions as regards using ABGA as a measure of viability and measure of asphyxia, but it's what we have. There are other advanced things, but we won't go into that. But when you're talking about the mild, you just observe. The moderate, keep an eye on too. The severe, you know that you're going to anticipating there will be more issues as time goes on. Those are the ones that are prone to having seizures, prone to having so many other things. And it also prompts us to look at why that particular child is was unable to breathe on time, because there may be inborn errors, structural defects that could have contributed to that. So what it does is to stimulate us to look further, investigate further, and find out what are the things, what could have been responsible for this asphyxia that we're dealing with. And when you have that, it's easier to take the management forward.
Okay.
So for a child that has severe asphyxia, then we need to look more to see, try to find out why. Even if it's not just for that child, but for subsequent children and subsequent pregnancies.
Oh, okay. Thank you very much, sir, for that. Jennifer Mesoma is asking, if the vasovagal reflex is stimulated, can the baby still be resuscitated? Can the baby survive and how can it be managed?
Yeah, once that happens, like any other child, any other person that suddenly stops breathing, we go into CPR, cardiopulmonary resuscitation.
Okay, sir. Thank you very much for that. So, to our audience, there is a link in the chat box. Just give us your feedback. Just follow the link, and it will lead you to a section where you can drop your feedbacks for us. So, Tete Abigail is asking, sir, please, with all the types of asphyxia, can baby start breastfeeding immediately?
Not with all the types of asphyxia. For the ones that were just observed, the mild and the more milder versions, yes, you can feed. But for the severe, sometimes it also affects their swallowing, the gag reflex, the sucking reflex. And when that happens, if the sucking is affected, baby will not be able to feed. If the gag is affected, it means that baby can easily aspirate food into the respiratory tree, and it doesn't turn out well. So if the child is severely asphyxiated, you do not start feeding immediately.
Okay. Thank you very much for that. Abigail, I hope you got the answer you were looking for. So, sir, what message do you have for mothers and healthcare professionals regarding the importance of neonatal resuscitation?
Right. My message really will be that the journey actually starts before the pregnancy occurs. We need to be prepared, to be pregnant in every way, medically, financially, physically, mentally. And then once that blood event has happened, we will need to put ourselves under care so that things can be seen when should be seen, and alarm ways before things become alarm. And to try and utilize the resources available to us, the centers available to us, where we can get good care, so to speak, and try and use places that are well equipped. Like I said, 90%, no issues at all, no help needed. But that 10% of 10%, you don't know who is going to fall in there. those ones will need help. For the medical people, I would just advise, know what your limits are. If you need help, please call for help. If you can't handle, please escalate. Thank you very much.
Okay, thank you very much, sir. Angela, if you're still here, we have maybe one or two questions for you, ma.
Yes, I am.
So you mentioned you talked about oxygen therapy. So, like, wanted to know, when is it necessary to introduce oxygen therapy during the resuscitation?
Okay. So, from the beginning, when I started, I said before you start any form of resuscitation, you are going to do some assessments. One of them is the ABGAS score, and in the ABGAS score, you're also going to check vitals for the baby. Part of these vital signs is SpO2, what we call SpO2. That's checking for the oxygen concentration that the baby already has. So having at the back of your mind the normal range of the oxygen concentration. Of course, if it is lesser than 94 and it is still dropping as you're doing all your resuscitation techniques, then at that point you should know that you should introduce oxygen for this baby to help the baby have enough oxygen circulation in the system. So with the help of the SpO2 monitor, you'll be able to know if the baby has enough oxygen in the system or not.
Okay, thank you very much, ma, for that wonderful explanation. So I also want to know, like, under what conditions should this resuscitation be stopped? Like, when should resuscitation stop?
Okay, after you have done all of these steps, remember I said all of these things are done by professionals, a midwife, the pediatrician. So just like the same way a doctor certifies an adult dead, the same way all resuscitations can only be stopped when a pediatrician says so. Okay, when a pediatrician mentions that, okay, at this point everything has been done and this baby doesn't seem to be picking up, that's the point when you stop all forms of resuscitation.
Okay, so thank you very much, ma, for that answer. So to everyone raising their hands, please, I would employ you to drop your questions in the chat box so that we can read and have our facilitators answer the question. And also don't forget that we have a link in the chat box where you can drop your feedbacks, and then we also have links to our social media handles where you can just give us a follow to know the necessary updates, upcoming webinars that you can as well join and learn from. So I don't know, thank you very much to our facilitators for this wonderful teaching. I believe every one of us learned something from this. Me personally, I did. I don't know about our audience. I believe they did too. So to our speakers, Matron Angela and Dr. Nwachukwu, thank you very much for this wonderful teaching. And then to our attendees, thank you very much for the engagements. Thank you to everyone who asked questions. Thank you very much. And to everyone who will drop feedback too in the link, thank you very much. So at Clearview Hospital and Fertility Clinic, so we are committed to advancing maternal and neonatal healthcare through teaching, training, and cutting-edge medical services. So we do a lot of things. Our services like IVF, hysteroscopy, laparoscopic myomectomy, and a whole lot of other services. So I would encourage you to come. Just come to Clearview and get to find out what we do. You can check our social media pages. I believe it has enough information that you need about Clearview. So please don't forget to follow us on all our social media handles, okay? Thank you very much. So until next time, stay safe and keep advocating for a better neonatal care. Thank you very much. I still remain your moderator, Ndukwe Queen Esther. So until next time, see you there.